Hi, welcome back to Rohrich Knows Podcast. I'm Rod Rohrich. I'm a board-certified plastic surgeon in Dallas, Texas. And today we're going to talk about faces, facelifts, adjuncts, all the things that are so hot today. You know, the deep plane, but also what do you do with a facelift? And I'm here with none other than Dr. David Hidalgo from New York City. David, welcome.
Well, glad to be here, Rod. Good to see you.
David is a world-famous plastic surgeon. He's a clinical professor at Cornell, and he's an outstanding surgeon, teacher, and really well-known in the entire world of plastic surgery for both breast as well as facial rejuvenation. So David, let's dive right in. So tell me about what type of facelift do you do, and then we can talk about the adjuncts, because today we want to talk about what do people do with a facelift? Because we always talk about, I had a facelift, but most of the time, you do way more than a facelift, correct?
I do. And, you know, there's a lot of confusion out there related to some of the jargon that people hear, like deep plane lift or
Right.
ponytail lift.
Yes.
First off, as you know, facelift just treats from the upper cheek to the base of the neck. It doesn't do anything with the eyes and the forehead. So a facelift is basically a procedure that will tighten not just the skin, but the deeper layers as well. And as we know, the deeper layer, called SMAS, S-M-A-S, is instrumental for giving a beautiful result that lasts a long time.
Right.
So there are some nuances on SMAS types, and we can get into that if you wish.
Yeah, and that's so correct. But what is the most common procedure you do with a facelift?
In conjunction with it, as a
Yes.
supplement or adjunct?
Yes.
Well, eyes, absolutely. Eyes, you can't let them alone. If there's a lot of aging in the lower face and you correct that, then all of a sudden patients will see their eyes don't match the picture. So eyes are done probably, I would say, 80% of the time that I do a facelift. Most common adjunctive procedure for sure.
Yep. No, I agree. And when do you do a brow lift? Because they're not done as commonly as we used to, at least in Dallas. Yeah.
Well, you know, Rod, the brow lifts got a bad name because they were such a invasive procedure originally. And then, as you know, we trended away from that and tried to find easier ways to do it. So we have less invasive ways to do it today, but they don't last as long and they don't work. So as a result, I don't do brow lifts very often. But if you really need to do one, the traditional way still works the best.
Right. No, I agree. And I agree that the endoscopic minimally invasive really didn't work. It didn't give you the results you wanted. So eyelids are also my most common procedure. So, and then what type of facelift do you do? I mean, and what Dr. Hidalgo said was that there's so much confusion about the deep plane. I mean, anytime you're manipulating the deep layers, the SMAS or below, you're in the deep layers. So it's not a new phenomena, but it's sure kind of wildfire on social media. So, I mean, I'm sure, like other excellent plastic surgeons, you vary it towards for the patient, right? You don't do, I just do this, right?
Yeah, 100%. I mean, you can't do the same technique for every patient, and that applies to all the different procedures that we do.
Right.
So in terms of tightening that SMAS layer, there's more than one way to do it, and I do it based on a patient's facial anatomy, their bone structure, their soft tissue configuration. Do they have heavy tissues? Do they have light tissues? What's their skin quality? All these things factor into what the best way is to tighten the deeper layers.
Right. That's well put. And so when people say I'm doing a deep layer facelift, I mean, all of us do a deeper layer facelift because we're using the SMAS. I mean, most plastic surgeons do some type of SMAS. It's a different type of SMAS, but I mean, I think there's been no study to show that one is significantly better than the other. The most important thing is safety, right? You agree?
Exactly right. And as you know, it's more surgeon dependent. Some surgeons do a technique that is better for them and get equivalent results to using a different technique in another surgeon's case.
Right, that's right. And it's all about safety and outcomes. And I know recently you've been talking a lot about lip lifts in our national meeting. So tell us about when that is indicated, because again, that's another hot topic that probably is overdone, don't you think, sometimes?
Yes, I would say, Rod, currently it's sort of a fad. And
Right.
as plastic surgeons, we're still trying to figure out exactly the role of a lip lift, when to do it, when not to do it. The things I can tell you, though, is that it's not commonly needed. As we age, the upper lip rather gets longer between the nose. The lip itself gets thin, and so this procedure, by removing a small piece of skin under the nose, will make that distance shorter and will roll the lip out so that it looks fuller. The problem is it's easy to overdo that. There are other things that influence when you might do that you have to be very mindful of. So it's not like some of the more tried and true adjuncts like chin implants and nasal tip plasties. You got to be careful with that.
Yeah, and I liked what Dr. Hidalgo spoke at one of our recent national meetings, and I liked your approach. I mean, you do it selectively, and you're very conservative, because if you overdo it, you can't go back, and it's a real problem.
100%. I mean, an overdone lip lift, it just doesn't look right, and there is no way to correct it. Yeah. So you want to be extremely conservative.
Okay. So what other adjuncts do you do or recommend in your patients? So you're doing a SMAS facelift, and you're doing other things in the eyes. So what are the other common things that you do that people should know about and ask for?
Well, Rod, most patients complain about their neck, and that's what brings them in. And then second to that is the jowl area here, where they start to see some laxity. So they focus on that. And what they don't really see as clearly is the middle of the face, which the facelift does not treat. The facelift treats the cheeks, the neck, but nothing in the center. And there are a number of things that we can do in the center of the face to enhance the results of a facelift. For me, the most common one is a chin implant, and most patients are kind of surprised when I recommend that, but they don't see themselves from the side. And a chin implant, the purpose is not to make the chin bigger or stick out more. It's to actually establish a corner so that from the side there's more of a corner and it doesn't just drop like that. And they're so subtle that most friends, family members, they don't even know it's been done. So chin implants are probably the most common, followed by resurfacing of the upper lip, because many patients will get those fine lines of the upper lip between the nose and the lip, and you have to do something about that to get a nice result. And there are several ways to do that.
Yeah. Well, let's talk a little bit about the chin implant. I agree. Starting with a little incision, in the submental area. I assume you do it there, not in the intraoral, right?
Right. 100%.
Yeah, and it's almost you can't hardly see it. And I agree with you. I think it's subtle. The key is to do a small implant most of the time and to shape it. And most of the time, a well-done chin implant, when you see the patient back, you don't even remember it until you look at the op note, right? You say, wow, you look good. Right. So it's a great thing to do, and they last a long time. They have a long, long period. I mean, it's not like a breast implant. I mean, I've had patients that have had their implants for 30 years. You as well, probably.
No kidding. And they don't have complications. I mean, yes, you can have a problem with anything, but chin implants, I can't remember the last time I had an issue with it either being crooked or infection or any of that. They're very reliable, very easy to do, very subtle, and it's a real finesse move that can enhance the results significantly.
Yep. No, I agree. So let's shift to skin resurfacing. Obviously, that's a very powerful technique, and I do it very commonly as well. Peels or lasers. How do you decide what to do, and do you do the whole face or mainly the perioral area? What do you?
Well, you can do it either way. I focus more on regional resurfacing at the time of the facelift, because after all, you're lifting the skin on the cheeks, and to me, it doesn't make a lot of sense to also essentially burn the skin on the outside at the same time. So what I focus on is the lip that I already mentioned. The lower eyelid commonly has very fine wrinkles or irides, as we call them. And either a chemical peel or a CO2 laser, those things can be safely done at the same time as a facelift, and you're hitting the biggest areas of concern. If a patient has skin that is mottled, a lot of sun damage, then I typically recommend that they come back and do like a full face Fraxel or laser separately from the facelift.
So when do you do a laser? When do you do a chemical peel? A regional one around the perioral area. What is it?
Well, we can accomplish the same goal with whether it's chemical, mechanical dermabrasion, or heat energy with laser. It's just what you're comfortable with. I like dermabrasion, which is just a mechanical tool that spins around. and it's like sandpaper, and
Right.
it's for me, it's more like an artist's tool, and I can just shave it down exactly to the level that I want, go no further. So I like to control, and that's why I use that traditional method.
Yeah. No, I've used dermabrasion. I use a chemical peel for lighter wrinkles, and then deeper ones I use a laser. But I agree. I mean, it's all about what you're hearing Dr. Hidalgo talk about is safety. Safety in the hands of an expert, and I think that's the most important thing. And sometimes, especially in social media, that's kind of a byline. And you gotta. The most important person in your outcome is your surgeon, especially in facial rejuvenation. So I can't overemphasize that. So what about facial fat grafting? I do a lot of fat grafting. Tell me, do you do fat grafting, or when and why? Or
I do, Rod, and I've gone through sort of an evolution in fat grafting. As you know, it's so popular now in our specialty, and it's used for everything. But I think the face is unique in several ways. First of all, the face moves a lot. And in my experience, when you put fat into the cheeks, for example, or around the mouth, center third of the face, there's a lot of movement just in the normal course of the day. And I don't think the fat grafts take very well in those situations. The two specific examples where I think it works really well is when you put it down deep on the bone, like for cheek highlights, and the malar bones, as they're called right here. I think it works very well for that, very predictable. I also think in some of our patients, in the older patients over 65, the cheeks are getting really thin because they've lost all their facial fat. I think it's great for the cheeks themselves here, but not at the time of the facelift, obviously, because you can't put fat grafts in and have them stay where you want. So I come back later and do that. And those two areas, the cheeks and the malar bones here, I think work really well as far as fat grafts in my hands.
Yep. No, I agree. I do facial fat grafting with most of my faces as well, and I love the deep malar and the cheek area. I agree with you, and sometimes I put it in the temples too, because that's kind of an early signs of aging, and that works great. So what is your typical post-op recovery for a facelift that you've just talked about with? And then tell me, when you add an adjunct, I mean, obviously when you add a dermabrasion or a laser, you add sometimes. So what is it? Obviously you're in New York, people want to get back to work. I mean, what do you tell your patients?
I tell my patients 2 weeks they're going to look very presentable, but not perfect. And what extends that by a week is the resurfacing that we're talking about, dermabrasion or laser. That takes longer. The actual surgical part heals very quickly, and the bruising tends to be minimal. There's a little bit of swelling. It's mostly under the neck, under here. But by 2 weeks, patients look pretty good.
Yeah, no, I agree. And sometimes when I do fat grafting, they tend to bruise a little bit more, especially around the eyes. We talked a little bit earlier about rhinoplasty. I mean, I do a significant amount of rhinoplasty with a facelift. I mean, and I've seen you do it and show it on on Instagram as well. So when do you think about doing a rhinoplasty or a tipplasty with them?
Most patients, as they get into the older age group, the nasal tip grows, the cartilages grow, and when they grow, the tip gets more bulbous and it tends to droop. Those are ideal candidates for just addressing those specific issues during a facelift because very effective. That's the area that needs to be improved. Doesn't add a lot of time to facelift procedures, which, as you know, can many hours doing many different things. So you kind of have to budget your time and do what's effective. So in my practice, it's rarely the older patient who wants a complete rhinoplasty. It's usually, the tip just doesn't look right. It doesn't go with the picture. It's a little too obvious. Those are the best candidates for doing an adjunctive procedure like that, which doesn't add a lot of operating time.
Yep. No, I agree. And, less is more in the aging nose and, bringing the tip up, sometimes taking a little bit of a bump down, just to make it, look like their rejuvenated face. Yeah, I like that. So David, tell us, some take-home points for the viewer when they're selecting a board-certified plastic surgeon to do their face, and just some points that they should consider, especially when they're looking at adjuncts as well for facial rejuvenation.
I think the first thing I would say is, many patients say, do I need a facelift? Am I ready? And what I would say is, when you start seeing a lot going on in the neck that catches your eye every day when you get out of the shower, putting on your makeup, whatever, you might be getting into the territory for a facelift. So those are the initial signs that might bring the question up. As far as selecting a surgeon, I agree 100%. You want somebody who's board certified. You want to go through their reviews. Reviews aren't perfect, but if you go through them, you're going to get a sense of the surgeon and their practice. You don't want to just pick somebody who's a superstar on Instagram. That's otherwise, as your sole criteria. And it's helpful if you have friends who have gone to this person. So, you get a more input that way. I would also say, as I said earlier, don't pay attention to the marketing labels that are kind of jargon like deep plane lift or ponytail lift. Just don't pay any attention to that. When you go see your surgeon, listen to other suggestions they have. You're focused on the neck and the jowls, but they want the whole picture to look good. So take into consideration what they suggest to you. And finally, leave yourself some time to heal. Don't try to jam this into the busy schedules that we all have. Just make a window, at least 3 weeks. If you got a big high-profile event, give yourself 6 weeks at least.
I agree.
Just so everything looks perfect when the time comes.
Yep. Wise words from a wise surgeon in New York City, Dr. David Hidalgo. It's always a pleasure to have you with us on our podcast, and we're going to show you your website and also how to contact you. David, it's amazing. I love what you do, and I do so much of what you do, and I can't tell you how much I appreciate you coming on to Rohrich Knows podcast.
Thanks, Rod. It's always a pleasure to talk with you. We always talk about some interesting things. Thanks so much.
Thank you.